So for those of you who don't know, Botswana is in the heart of SADC. We're landlocked. We don't have very many people, just a little over 2 million. We've been very lucky. We have a very well-developed medical infrastructure, quite a few clinics, and 34 standalone HIV clinics. Our number one public health concern right now is, apart from HIV, is tuberculosis and cancer. It's really now the leading cause, and cancer has now caught up to tuberculosis as being the number one killer of people with HIV. Our overall prevalence of HIV is 18.3. I realize I missed that. So we've been lucky in Botswana, and mainly because we've had political support from the beginning, and we've had resources, and we've also had very strong development and research partners. So we started off on a good foot, and so we were able to do things a little differently from the beginning, and I think that's really why now we're seeing the success many years later. We were the first country to be able to have routine viral load testing from the beginning, resistance testing and viral load testing from the beginning. And we felt back then we shouldn't have a double standard. We shouldn't say, you know, this is the way we do it in the United States or Europe, but this is how we're going to do it in Africa. We also went ahead and provided a tripla for pregnant mothers in PMTCT before WHO recommended it. And we used Combivir from the beginning. We didn't have to use D4T and DDI, and we were using raltegravir and darunavir since 2008. So this is just to show you the progression of our first-line regimens over the years. Our new regimen, obviously now is Truvada and DTG. We'll consider TAF when it comes in. We're going to have resistance testing after first line and see what we find. So we've done well. Our PMTC rate is 1.1. We're pretty much have achieved the 90-90-90 targets already. And we have probably the best viral load suppression in the world. We've just did a chart review of 90,000 patients, and it was 96% suppression rate. So, but we still don't get on the charts here, so I showed this to complain, because this was presented at CROI, and really Botswana is somewhere up here, but you don't see it anywhere here, so I just had to put in a word for us, because we're busy implementing sometimes and always doing research. This was simply just to show you that we've actually done well across the board as far as first-line failure rates are concerned, and we watch it very carefully. I'm going to be showing you lots of surveillance data. And this is a cohort of 3,200 from Princess Marina Hospital into surrounding areas in Gaborone, which is the capital. And it really highlights some of the things that Francois just mentioned. To begin with, we can see that we have an aging. So what we wanted to see, so you know, early warning indicators was fine and all that, but we wanted to say what's happening really with those cohorts that started treatment in 2000, 2002, 2005, 2010, and to compare these as far as first-line failure rates were concerned, and how are those patients doing. So you can see, and this was updated at the end of 2015. So you can see here what the N is, but when we look at deaths, for instance, still the cohort from 2002, which were very, very, very sick patients, we still have 70% of them are alive and still on treatment. And you can see how it goes from there. Loss to follow-up also we've done fairly well with. But this is alarming here. Excuse me, this should say 36, not 6. But we see less and less males in treatment, mainly because we believe of B+. But this was an issue for us when we see kind of the difference between females and males. And we have an aging cohort. So more and more people on treatment and more people getting older, and we are concerned about comorbidities. Our average CD4 count has gone up, but mainly because of B+. So we have about 270,000 people on treatment. All-cause use of PIs, which we take as a proxy for first-line failure rates, is 12%. 40% of our patients are still on Combivir, efavirenz, or nevirapine. So we have this old group of patients now that are really starting to see a lot more lipodystrophies and long-term side effects from use from those older regimens. 60% on Truvada-based. I told you about our increasing comorbidities. We also have an issue with healthcare providers and staff, and we haven't been able, our heyday really was 2009, 2010. We had a lot of money from PEPFAR. We had a lot of positions, staff positions supported. Gates pulled out of Botswana around that time, took 350 different cadres of healthcare workers with them. PEPFAR also started to take money out, about 20% a year. So we were seeing that we needed to do something different, and we needed to be careful because our systems really didn't have advanced training in HIV care well developed. We had a wonderful kind of fundamental HIV care program, but not advanced care for HIV. So by 2012, we were getting worried. Actually, Botswana survived the 2008 economic downturn quite well because they had great reserves in the bank, and Botswana is very tightly fiscally managed. But all of those reserves were used up over the following 2 years. So by 2012, we were worrying because the kind of financial resources that we had in the country were no longer going to be there. And also we had this huge pullout of donor support. So we started to look kind of economically and working with economists doing some macro analysis. And we could see that, the average economic growth through 2020 was going to go down from 9% to 3.3%. Mineral revenues were dropping. They were dropping more than half. And total government spending was going to have to drop really by 25% again to stay fiscally managed. And that meant that the government essentially pulled 10% of all of the positions across all ministries equally. So not only did we have a huge a gap in healthcare workers from development partners, but also the government was not hiring people so that they could actually continue to have a financial equilibrium. And so really, there's going to be a 12% cut beginning in 2014 all the way to 2030. So that was one thing that made us a little worried, and this was another thing that has made us very worried, which is these are the biases. There's 3 biases that beginning in 2004, 2008, and 2013. And we basically wanted to look at what happens to these young people as they age. So if you come down here, this is a cohort that is 10 to 14 in 2004. What happened 4 years later to that cohort, and what happened another 4 years later? And you can see for all of these young cohorts that by the time, within 8 years, their prevalence was increasing. And of course, in 2004, these 10 to 14-year-olds were basically still not so sexually active. But as soon as they became sexually active, their prevalence really increased. And here, people that started as 15 and 19-year-olds now were surpassing the average national prevalence rate. And so it goes. So we said, we've done this incredible job with treatment, but we have failed miserably with prevention, and we have failed miserably with prevention with young people in particular. This is another study that we did this past year, which was an incidence pattern study that was designed by people from the University of London, and it was a really elegantly designed study that Botswana was the first country that they were piloting at. And essentially what this study does is tell you the following year where people are going to be infected. And what we found, again to our horror, was really it was young people, less than 25-year-olds, that were going to account for 35% of all the infections in 2016. And also, never married women in 25 were really contributing the highest proportion in most districts. Also interesting, I think this scared people too, is that the other place where new infections were happening were in seronegative couples, so really married couples or long-term couples that thought that they were really safe and probably not condomizing. That's really where the infections were going to be. But essentially, we really saw that, again, it's young people that were missing. This is some data from the BCPP, the Botswana Combination Prevention Trial. This was actually published in Lancet, showing again, we have almost reached the 90-90 targets, but when you look at which patients, as far as viral load suppression, are not actually being suppressed, it's these young people, 16 to 29-year-olds, and of course, males. I shouldn't say of course, but they tend to be more problematic. But there was hope too. So this is probably around 2015 is when we were really trying to put our thinking hats together and go, what are we going to do? We have a problem. How are we going to address it? So of course, Botswana was one of the countries that participated in the trial 052, and it showed us that 93% decrease. You know this about transmission with couples, and also now dolutegravir came on the market, and we said, okay, let's talk about this. So we decided to put a task force together, and basically UNAIDS was, I'm sure many of your countries have put together an investment case, and we had actually put the investment case together 2014, 2015. We said, let's go back actually. Let's go back and look at all that data and start to model what would happen if we did test and treat and actually use dolutegravir. So the methodology we were using the spectrum model. For those of you that know about models, it's the model that UNAIDS basically asks all countries to participate in and to do every year to complete your GARP report. So Botswana has a lot of data, more than most countries. So we actually can use the full spectrum the full spectrum of spectrum, because we can activate a lot of different modules that are there. So we did it, and we put together a technical working group and worked on this model pretty much nonstop for almost 9 months to say, let's really get the very best data that we have in the country and see what happens. And what we found, to our amazement, really, was that, especially because if Botswana never changed the treatment guidelines from 350 to 500, because we really felt there wasn't enough clinical data to do that. And also we felt during that period of time, really after 2010, our healthcare systems were quite weak. And we said, let's try to really make our healthcare systems a bit better before we make this decision and also see what happens. But when we did this analysis, what we found was that treat all with dolutegravir use was going to be the most cost-effective option. It was going to see the greatest reduction in the number of HIV infections, the greatest decrease in annual deaths, the largest decrease in the number of tuberculosis cases, toxicities, treatment failure, and that we might be able to gain epidemiologic control of HIV by 2020. I was sending SMSs out to my friends. It was really exciting. It was an exciting moment. So this is a graph of epidemiologic control. So here is 0, and we're defining epidemiologic control as that point when the amount of people that are dying off from HIV, not necessarily dying from HIV, is going to be more than people now that are being infected. And so the 3 different models that are represented here, this blue is our current CD4 count 350 atripla. The red is CD4 count 500 atripla, and the green was the treat-all dolutegravir. And we ended up with these 3 models because we knew from the data from START that really where we would see a big improvement in mortality and morbidity would be above CD4 count with tuberculosis and cancers. So this is representing the new infections. And again, if we hadn't done anything, we knew exactly what was going to happen. So right now we have about a little over 12,000 people that are being infected with HIV annually. If we didn't do anything, that number would increase to 13,000. With the dolutegravir treat-all, that would go down by about 10,000. And the difference between these two was between 10 and 12,000, so it was significant. Same thing with deaths, essentially the same thing. Cost, and this was another wonderful moment for us, I think, because while we would see a bump in cost to begin with, especially because we decided to go ahead and buy dolutegravir before it becomes generic, eventually we know that the cost is going to decrease really probably after 2018, and by 2020, 21, it becomes the cheapest option as well. And that's mainly because you don't have failures, you don't have as many toxicities, you don't have as many hospitalizations. And because your HIV population decreases. So we do see a funding gap, and we talked about that. And what was important here was, yes, we had a funding gap, but we were able to actually quantify what that funding gap would be, and we hadn't done that before. So a lot of people were saying, it's going to be too expensive, it's going to be too expensive, but we were able to actually say, well, actually, this is about what it's going to cost, and then go to development partners, and then go to Parliament and say, are you willing to make this strategic investment? Because that's really what was important. And what you can see here, and this is another, we've actually been criticized over the years for having what they called the Cadillac model of HIV care. But in fact, I think Botswana has proven the point that providing the best quality HIV care is the most cost-effective thing to do. And also that even with the gap, it was only going to have to, well, I say only. People go, Ava, you can't say only 1.4 of total government spending. That's a lot of money. But I think it's important in the sense that people think that the HIV program is the most expensive program in the country, and in fact, it's not. So we were able to actually go to Parliament with really good figures and say, this is really what it's going to cost you. This is the price tag. And what we could see is that if we didn't, even going to CD4 count of 500 would have been obviously more expensive than CD4 count 350. But it was only with Treatall and DTG use that we would see an actual decrease in total expenses for the treatment program through 2030, and this is really important. So, again, this is just about the funding gap and overall costs. We also looked at summary of cost of death, infections averted and deaths averted. And again, the cost was so much less. I mean, the difference in morbidity and mortality was so much less with the DTG model that, again, even if we were only 50% accurate and you wanted to criticize us, it was still a major shift in cost for ART care. But not only that, we knew also that with the decrease in tuberculosis cases, with the decrease in hospitalization, we're also going to have productivity costs also go down. And in fact, the Botswana National Tuberculosis Program is going to present the data that they did separate on the decreases that they're expected in the tuberculosis program and the cost, and it's very significant. And obviously, because we don't have enough healthcare workers, this is extremely important. So again, wonderful political support. The permanent secretary put together a task force in November and said, let's really pull everybody who's doing anything in the HIV movement in Botswana. Let's all get together in a room. Let's put our heads together and figure out how we actually can make this thing happen. And she personally is chairing that task force and also really mitigating the implementation risks. So our plan is that over the next 3 years, we're going to initiate 100,000 more people. And we're going to begin with different focuses over those 3 years, beginning with youth immediately, and doing everything that we can to make sure young people understand their risk of HIV acquisition. In 2017-18, it's community interventions. We finally got, the treatment program finally got a Global Fund grant, and a lot of that Global Fund money is going to build help build capacity in NGOs and CBOs. So we figure they'll have had funding for a year. Let's go back now and see which things in the community actually work and which things we can continue to fund long term. And then last year to really improve our surveillance systems and mental health. And we really have not seen what's going to happen with people with adherence as far as being well and being put on treatment. And we have a very weak mental health infrastructure right now, so we really feel we need to make some serious investments there. And so beginning 2016, all the new initiations with Truvada and DTG. When TAFT, towards the end of the year, we said we'll make a decision about TAFT and see what to do. 2017, we're going to transition people who have been stable on lopinavir, about 26,000 patients, onto DTG. And 2018, we're going to think about moving these older cohorts. And we're giving ourselves a little bit of time to also follow the science, see what happens, see what the best direction is there. For now, we are going to put pregnant women on DTG. We feel that there's every reason to think that they'll do fine. We have been putting pregnant women on raltegravir for quite a long time, especially those women that came in, those late presenters, so that we could get their viral loads down, and we haven't had any really problem at all with that. So if a woman is on an older regimen and pregnant, she's going to stay on that regimen, but any new woman who is diagnosed pregnant will be put on DTG. We'll also use it in tuberculosis patients and follow them. So we're trying to do a few new things. We have to really increase our HIV testing capacity. We're going to be piloting home testing. We need to improve our functional linkage to care. We're also piloting same-day initiations. And we're trying to find all of those patients that we've been tracking with CD4 counts over the years and tell them to come into care. We've had to restructure our M&E systems. Again, when the partners pulled out, a lot of those positions were M&E positions. Now we're trying to really scrape from the bottom and redesign the whole system, again, using quite a bit of high-tech real-time reporting. Basically, also the important thing of talking about a new narrative for HIV. And really, I think one of the best things that's happened from making the decision about Treat All is suddenly everyone, again, is really inspired about the HIV program. It's like a reinvigoration of what we were doing that was really lacking. People were quite depressed about HIV. But when the government made the decision to move forward with our recommendations, people have been really, really supportive and wanting, again, to do new things. So the new narrative, no one should ever become ill from HIV again. You know, we're on the road to epidemiologic control. We have the same life expectancy. Oops, sorry. Test early, treat early, live long. Our campaign was launched on June 3rd by the president. It was very exciting. In 1 month, we've over doubled our normal initiations, and this is before we have launched a large new IEC campaign, so people are already coming forward. We updated our clinical guidelines, and we are also in the process of doing system integration. And this is really important, and we feel it's important because of the comorbidities that we're beginning to see. So really, in conclusion, implementing the Treat All strategy with Botswana, we expect to see the greatest cost savings, control of HIV, which is really incredible, significantly decreased mortality and morbidity, and essentially the financial benefits of decreased infections and mortality far outweigh the initial investment that we have to make. So people say, can you really afford Treat All? And we really say, well, we don't feel we can afford not to. So many thanks.